So we're going to go ahead and cover the topic of metabolism in heart failure. So, metabolon, metaboli, to change. It's Greek, and it is what we've been talking about. How does shock evolve? Well, the metabolism probably has a lot to do with it in terms of the biology of how shock changes your likelihood of survival and how shock changes overall. The heart is a metabolic omnivore, massive consumer of energy. It has to cycle out of ATP. It cycles its weight 12 times daily. And as far as ATP mass. And how does it do it? Through a flexible utilization of substrates. You guys just had lunch, and right now, trust me, you are not using lipids. The heart is not using lipids. It's using glucose and glycogen stores. Overnight, especially if you're into fasting, I eat late at night, but some people don't. You will begin a program that is evolutionarily fit for using fatty acids, which the heart, when it's normal, can do very well, but at a cost. It's okay to be inefficient when you sleep, though, because you're sleeping and resting. So this seesaw, these are a slide from Dr. Opie, South African brilliant cardiologist who worked on cardiac energetics while he saw lots of patients. Dr. Opie talked about the cardiac energy metabolism having a flexible substrate switch. So you see what you want to do is get acetyl-CoA, the common unit, the 2-carbon unit for the TCA cycle. You get there through fatty acids and glucose through a seesaw mechanism. So Galveston, Texas, I don't know if Jaime is here. This is George Herman and George Desherd. This is a lab that was famous for beginning to look at cardiac energetics in the heart and in the failing heart. And what he says, it's outlined in green. I'm just going to read it very quickly. Every clinician has witnessed the death of patients with evidence of complete myocardial insufficiency, only to have pathologists offer nothing more than slight microscopic myocardial changes to account for the clinical picture. Everybody knows the mild hypertrophy, mild fibrosis. You're like, wow, this patient's dying and he has mild this. Now, that's only half the story. And metabolism can help fill some of that in, we hope, in the next several years. And the time is now to do that. So, again, 2012, what was the prevailing theory about heart failure and energetics? That the heart had a metabolic switch to glucose, that the heart had a mitochondrial dysfunction, that the heart decreased its fatty acid oxidation, so therefore you were accumulating lipids. These are the three tenets, 2012, all based on animal models. And then came a publication that was done by Christian Schulze, a colleague of ours that's now in Jena. He's a cardiology chief at Jena. Schulze and his lab at Columbia found that the heart was depleted in certain metabolites, lipids, but it was enriched for ceramides and what we call toxic, lipotoxic metabolites. So this is an editorial that I did. The point of this figure was to go ahead and show that the patient that has advanced heart failure becomes cachectic through a lipolytic mechanism. We burn fat. It's not just muscle sarcopenia. You are burning fat like crazy when you're in heart failure, when you're in advanced. That's why the weight changes so quickly. And then what happens is that fat has to go someplace, so you get lipotoxicity. Now, back to George, the George brothers from Galveston. These two gentlemen basically were the first to identify an insufficiency of a chemical, a metabolite for energy, and it was creatine. And they found a creatine deficiency, this is phosphocreatine included, which is an important element that gives you a buffer system in the muscle for ATP. So, is a heart lipotoxic, energy starved, or insufficiently, or inefficient as far as its workload? So we started working on this when I was at UCSF as a junior attending. When I came to Penn, thanks to Ken Margulies, we were really able to rev up this work, which is, let's look at the lipidomics of the heart. So we had non-diabetic, non-failing, end-stage heart failure patients who gave their heart tissue to us at the time of transplant. Ken Margulies has one of the biggest biobanks, and you can collaborate with him on whatever you want. He's an amazing collaborator. He's my partner. He's got the largest biobank of end-stage hearts, 12,000 end-stage hearts he has as a biobank. So we did unbiased and targeted mass spec on non-diabetic, lean, non-ischemic patients with heart failure. What do we find? There is the patients we chose. The first run, this is a plot with the size being the p-value, and there's the fold change, and you see that most things are down. So red is down in heart. This is normalized to non-failing normals that were also procured. Look at this is palmitoyl-carnitine, one of the most important acetylcarnitines that goes right into the fatty acid oxidation. You can barely see it in failing. Look at the variance, very little variance. I couldn't believe these results when we first looked at them. I said, wow, this is definitely speaking against the lipotoxicity. These fats are depleted. The failing end-stage human heart, non-ischemic, is burning everything. It is an engine out of fuel, as Stefan Nubar called it. So this is the acylcarnitine work that we did. We found the acylcarnitines to be low. We confirmed in a totally different cohort. I didn't want to publish those results because I said, this is crazy. There's no lipids in the heart. So then we did finally publish it. There is the data with the failing hearts basically being, the red is, enriched lipids. The failing hearts have almost no lipids, including acylcarnitines. And when we looked a little deeper at the other metabolites, we found that the TCA cycle was altered as well. We found specifically that you had a deficiency of succinyl-CoA, so there was an interruption of the carbon cycle, the Krebs cycle. And so you have a deficiency you have basically a Krebs cycle that cannot cycle acetyl-CoA. You have insufficient substrate. We also found beta-hydroxybutyrate to be increased, beta-hydroxybutyryl-CoA. So we saw evidence for ketogenesis in the heart, and that led us to the theory that maybe the heart was also utilizing ketones, which come from the liver. I talked a little bit about that yesterday. So fast forward now to 2016. We published this. We published it jointly with Dr. Dan Kelly, who's also at Penn now with us. Thanks to this collaboration, we brought him to Penn as the CVI director, and we're working out together on ketones. Both of these publications got the attention of a colleague of mine from Oxford that I knew, Kieran Clark. And now, what we are doing is a first-in-human heart failure trial for ambulatory class 2 and 3 heart failure with a ketone ester drink. Let me show you some of the data, and then I'm going to just wrap up here. So this is data from a pacing-induced heart failure model, which shows that you get noradrenaline up, you get fatty acids up, and that fat correlates with uncoupling protein. So fat is inefficient. You're uncoupling to ATP, you're losing the energetic drive. Then, so where do ketones come in? Ketones have a huge flux. Look at that, 0.1 to 11 millimolar. That is the ability that your liver has to generate a lot or shut down ketone production. So a ketone ester drink was made. DARPA is a defense fund, and they wanted military men to have, and women, to have a ketone ester drink to develop better performance. So $10 million, and they developed it. This is Kieran Clark's lab, called Delta G. And Delta G, from the Gibbs equation, is able to generate a mild ketosis. You see there on the green and the yellow. That is perfectly controlled. You can actually modulate a mild ketosis. So and by the way, they proved it in athletes, incredible performance in athletes. So our hypothesis was that you would actually be able to improve the energetics of the heart with ketones via a mechanism that basically involves both the use of ketones and an increased uptake of glucose. We're going to try to prove this with the grant that we have at Penn. So I'm the PI in this human phenomic science grant that we're going to do a first-in-human shot with 12 to 15 patients. And the clinical perspective for shock, of course, it's a shock conference. Dr. Carr and Marwan asked me to talk, but I think I wanted to present what's potential and not what's theoretical. We have no data for what is metabolically deficient or important in shock yet. There's some data from the past, and I'm just going to go through. We have the energetics of the heart here. We know that in shock, especially, this is, for example, on ECMO, look at the pressure-volume relationship, and look at also the PVA, which is correlates with the energetics. Look at the RV. The RV, when it fails, look at the energetics of the RV going from normal, that triangular shape in blue, to RVH, and then to RV failure. So in conclusion, I think shock has a huge potential for a metabolic adaptation paradigm. We need to get there by proving safety in humans first. I would never start with the sickest humans unless they're dying. So I think we're going to do the first-in-human heart failure. Thank you.
About seven minutes for questions for Eddie. We can't see, so you have to yell if you're out in the audience. Or moderators, any questions? I'll start.
I'm sorry it was so quick.
That's what it's supposed to be.
Yeah.
Is there any role, drugs like trimetazidine and other partial fatty acid oxides have been used in HCM or tried and other. Is there any role for this, or is it so out of fuel of every substrate that doesn't matter and you have to supply it in a different way?
That's a great question. So when I first entered the field, so trimetazidine is a CPT1 blocker. You also have perhexaline, the number 2 antianginal in Australia. Any Australians here? I wanted to get that when I was at UCSF for my patients with angina and heart failure. The FDA didn't allow it because of a liver injury issue, but it's now totally safe. We should reintroduce that. These are two medications that increase they block fatty acid oxidation. So they increase glucose. Jim, they could be tested as a model, but the problem with that is the failing heart, and I think the cardiogenic failing heart too in shock, is going to burn fat. I don't think you can block that. And if you did, I'm not saying fat burning is necessarily bad. What I'm saying is if you give the human or the organism a chance to basically have another substrate like ketones that enhances glucose oxidation. The ketogenic diet is an example of this. The problem with the ketogenic diet is it's a fatty diet. So I showed how fatty acid levels go up in the ketogenic diet. I didn't show that, but it does. That causes uncoupling, and you have less efficient heart metabolism. So, but all of this is a good question. I think we need to be broad-minded, need to not have a bias. A lot of the basic scientists have a bias because of their animal models, and I think if you're a clinician scientist or you're a clinician, you don't want to be biased. That's what I was taught by, in my acknowledgments, I have 3 intellectual acknowledgments to make, which are Roger Unger, Dennis McGarry, who passed away, and Dan Foster, who passed away, who are my chiefs at Parkland. Those are they were mentors of mine, and they were people that were into metabolism. That's the inspiration I got as a resident.
Some of the changes you observed seems to be a little bit similar to those observed when you have a mitochondrial dysfunction, and the way to use ketone diet is also a way to counteract it. Do you think that altering the nutrients is the way to go, or should we try to modulate mitochondrial function by other ways or other drugs?
That's a great question. There's no time in this talk to talk about too many other things, but if you think about it, there's a substrate utilization, then there's the factory itself, the mitochondria. How do you affect the function there, the oxidative phosphorylation? I think this is a wide open field. I think the question is safety and how do you begin targeting, because we already know that patients with ischemia have first of all, patients with ischemia and shock through the peroxynitrite mechanism, they poison their mitochondria. So you have a total halt of energetics. That's why the lactate goes up when your blood pressure is adequate in sepsis and you're vasodilated with like 10 pressors. It's not necessarily the ischemia from the gut. It's the effects of sepsis on the mitochondria. That is a field that I don't know much about mitochondria, but I think it's important. We focused on ketones because of our discovery in heart failure. I don't know how important it is in shock. Dr. Clark did publish several papers on the oxidative phosphorylation enzymes, and she saw deficiencies in heart in the ischemic or failing heart and the diabetic heart.
Eddie, I want Jay.
The minute you mention dietary supplement to enhance performance, we all get excited.
I'm glad,
So
Jay.
if you look on the internet, you see dozens, if not hundreds, of ketone supplements.
Yes.
What makes yours or your scientific work more focused or better than all these dozens of other supplements you can get at the health food store?
My total bias that I went to Oxford for 2 years. I'm just joking. No. Karen Clark, what makes this ketone supplement, I think, more predictable is she has the most human testing in normals, in athletes, the most. And I'm not conflicted. I have no conflict. She is. She was the founder of that company, whatever it's called. Delta G is in the market. I just didn't want to tell you guys in case you guys wanted to steal my idea and do the first in human cardiogenic shock patient. But it is available. You can buy it right now across the street in one of those places that sells this.
Yeah.
The issue is safety. And when we went through the FDA for doing it in patients, you have to go through a rigorous approach that says this is commercially available in the US, made in Europe, made in the UK, in Scotland, or Northumberland, but here available. That process took 6 months, but it's there now for other people to use in a certain scenario as an example. I would say look at the number of patients, because these nutraceuticals are easy to pass through the FDA. But if you want to use them for disease states, you better do your homework. So we're doing that now. We're doing the PK studies first in human. Before we go to the heart failure patient, this was brought up by my chief, Tom Capola. It was a great idea. Why was the iron out study negative? Because nobody did PK studies. I mean, you took iron supplements and it made your GI system upset, but nobody did PK studies. So we'll see how it goes.
So your big secret is Delta G, right?
It's not my secret, it's Kieran's, but yeah, that's what we're going to use.
All right.
Yeah.
Thank you
You're
very
welcome.
much.